Okay. So the webinar today will actually be focusing on more on that concept to kind of change it, to kind of confront it, and bring out the view that it's actually okay to not be okay. We are not robots, we are still human. And as you can see in the next slide, most of the times they find themselves in a position whereby even as they say, I'm fine, what they actually might mean is save me, because they are deep in psychological turmoil. We'll begin by maybe going through the definitions first of vicarious trauma. And the vicarious trauma itself, it refers to the negative changes in the view of self, others, as well as the world in general, as a result of repeated exposure to someone else's trauma, or extreme exposure to aversive details of a traumatic event. So most of the times it's focused down onto either health professionals or healthcare workers, or anyone basically who works with traumatized patients. So it's based on the constructivist self-developmental theory of personality, which conceptualizes trauma as a disruption of human development and adaptation, especially with regards to needs for safety, self-esteem, trust, control, independence, and intimacy. So the theory itself, it's a theory that views trauma as something that basically depends mostly on the person's history of on the person's personal history, so that its view is that it's the history that will now determine the adaptation of that same individual, as to whether the reaction will either be in extreme or not extreme, or they'll be able to have that resilience. So initially, the vicarious trauma had only been identified with trauma survivors, but later on, it had been proved to actually affect healthcare workers as well. And as I had said before, it's not only healthcare workers, but anyone else who interacts with people who've been traumatized. For example, we have the law enforcers and others who will be working with severely traumatized people. So vicarious trauma, it's usually related with several other concepts. And it's very important to know that these concepts, most of the time, they concur at the same time, but then they are still distinct in a way. So they may be related, but they are a bit distinct. So as we had already said that the vicarious trauma, while vicarious trauma, it actually focuses on the negative transformation of a service provider through an empathic bonding with traumatic experiences of their clients or patients. You find that now the other two concepts, they're a bit different because the compassion fatigue, for example, its focus is on the empathetic exhaustion and strain that results now from caring for the people who are in distress. And is also often associated with people in the helping profession. So it's basically linked to wearing down of empathy and compassion. Burnout, on the other hand, is more of a persistent state of exhaustion, cynicism, and inefficacy due to stress from dealing with difficult clients, patients, or the role that someone is in. In the example maybe of any healthcare worker, maybe a social worker, a psychotherapist, a doctor, or a nurse, in the roles that we are in, there are several responsibilities that we have to carry out. So at times we find that it becomes like too overwhelming. And so the stress that comes from dealing with the responsibilities that come with the role that you're playing, some of that may contribute to burnout. So the symptoms of burnout usually include frequent absenteeism, especially when related to your work area, and chronic tardiness and underperformance in their work. This is again will emphasize that those three the three concepts, they are related, but they do not exist independently, but they can also occur simultaneously. And to add on that, not only can they occur simultaneously, but you find that in some instances, one may trigger the or develop into another. So after having defined vicarious trauma, the effects actually, they may not always be negative. You'll find that there's a negative effect of vicarious trauma, and also a positive effect of vicarious trauma. This may be due to, as we had said before, it stems from the constructivist theory of developmental personality. So depending on the on an individual's past history and their ability to be, or the vicarious resilience to now determine whether the effect of the vicarious trauma will be on the negative or on the positive side. So for the secondary traumatic stress, this is now actually the negative aspect, the negative impact of vicarious trauma. Now that is the one that's referred to as the secondary traumatic stress. It basically refers to the negative emotional and psychological effects that are experienced through vicarious exposure to details of the traumatic experiences of others. Symptoms may include insomnia, nightmares, irritability, hypervigilance, intrusive thoughts, and at times even reliving the traumatic events of the clients or patients that you have interacted with, and as well as negative alterations on the view of self and the world. Yeah. So if I was just to give an example, health professionals, for example, who work with sexually traumatized people, most of the times you may find that as a result of that, there come some cognitive alterations. Maybe they may develop the thinking or the belief that all men in the world are bad or something of the sort. So while on the other hand, we now have the positive impact of vicarious trauma, which we now refer to it as the vicarious post-traumatic growth. So this is now the positive changes to the self, interpersonal relationships, and personal life philosophy as a result of the internal struggle with adversity after our vicarious traumatic exposure. And indicators of this growth may include positive character changes in the person of the health worker, spiritual growth, enhanced appreciation of own good fortune, pleasure in witnessing the client's or the patient's growth, and greater personal strength. So now within the pandemic, in regards to the COVID-19 pandemic, you find that the pandemic has now come with its own factors that also now contribute to vicarious trauma among health professionals. The pandemic has come with a great increase for the demand of healthcare services, and with the demand, as you remember before, there wasn't there wasn't the employment of new staff to assist. And you find that the healthcare workers had to face even longer shifts, and there was more work that had to be involved. It had to be involved in. And then if you consider that with the COVID-19 protocols that we usually have, even though we may try our best to stick to them and observe them, most of the times it's not each and every health facility that will be able, that has an infrastructure that can actually accommodate all those protocols. For example, the other day there was a healthcare worker, a friend of mine, who actually had told me that on his side, the PPEs that the PPEs that healthcare workers they usually use, so that as a protection when interacting with people who are positive for COVID-19. On their side, since such resources were really rare, they would reuse it after each and every person uses. So once one has used it, it's washed, and then the other person uses it again, which actually beats the fact of or the sense of using it in the first place. But that is what they had to do with the few resources that they had. So you find that more and more healthcare workers are now being vulnerable to infection, as well as psychological strains that may lead to mental health issues. There was also a very great uncertainty and insecurity that was caused by the pandemic. And this, in so many instances, it led to their interaction or their relationships with those who are around them. For example, one of the greatest issue that was arising among the healthcare workers was the fear and the possibility of spreading the virus to family and loved ones. So most of the times they would isolate themselves. They would change their routine. Maybe they will show more withdrawal and begin to narrow down the support network. Now, as you know, with all those behavioral actions, when you begin to narrow down your support network, you're trying to cut off the family and friends, even though, yes, it might be for a good reason at heart, but in the end, this affects you not only emotionally, but basically your psychological well-being. So this may lead to some of the symptoms that they now begin exhibiting. We have the loss of appetite, the fatigue, physical decline, maybe the loss of weight, sleep and attention disorders. Some of them you find that they have nightmares and or dreams regarding the clients that they have just interacted with and the traumatic experiences that they've gone through. We also have irritability, numbness, fear, despair, and feelings of loneliness. Then it now also comes, there's also the cognitive symptoms. These include negativity and cynicism. And you find that there's quite an alteration in their thought patterns. In the beginning, maybe before the exposure, the negativity and cynicism was not there. But after the exposure, they slowly developed that. And then there's also the trouble in remembering things, preoccupation with thoughts of the traumatic event, and constantly feeling that they are not doing enough for those who are under their care. The behavioral symptoms, as we had already stated, they include isolating themselves, avoiding people, or even ditching some tasks. For example, you find that this role, the having to interact with your clients, at some point it gets overwhelming and you just don't want to interact with them anymore, and you begin to find some small excuses that may exempt you from performing that role. And then there are others who now work more days and hours, stemming from that worry that they're not doing enough for those who are under their care. So they begin to work more and to push themselves to the limit, to strain themselves more than their body can take, and they work more days and hours. There are others who will now react with alcohol and substance abuse, majorly in an effort to try and forget, or to try and forget, or to try and stop thinking about, constantly thinking about the traumatic events. For example, if it's someone who is constantly having nightmares of the traumatic events that the clients are having, most of them maybe they may go to alcohol or substance abuse, which we know most of the times when you get drunk, you just fall unconscious or just sleep. And then we may have increased erratic behavior, or as we had mentioned before, lateness or absenteeism at work. So this now leads us to, after all that we have now said about the vicarious trauma, how do we intervene? Now there are several intervention strategies that have come up, and that have been shown that can actually help. Other than the self-care strategies that on an individual level, one is expected to make sure that they observe so that they can take care of themselves first. You find that there has also been the need for it, not only for that responsibility, not just left on the individual, but for the organization or the institution that the individual is working in to also help them out in a way. So that's why we've actually separated the interventions to individual level and organizational level. What both levels can do to avoid or try and build resilience among the staff. On an individual level, as you had mentioned, one can go through self-care, and this may involve involvement in leisure activities, exercise, healthy diet, mindfulness through reflection, conversational activities, or even spiritually based activities, and humor. And I'll just like to emphasize that the humor here, you have to make sure it's genuine, because if it's just a mask, then you won't actually be doing anything. You also try to maintain a good social support network, have the regular interaction with the family and friends. It's really important for each and everyone to have that support social support network. Really helps in the emotional and psychological support of the individual. Then we also have therapy. If at some point that they feel that they've reached a level whereby they are really overwhelmed, then they can feel free to go for therapy. And going for therapy does not necessarily mean that you really have a problem. No, it just means that you're going to seek a service, and because we, as I had said before, we are all human, and it's okay to not be okay. So you're just going to seek a service so that at least you can have that peace of mind once again. Now, from on the organizational level, there's the organization or the institution can try to develop a supportive and non-judgmental organizational culture that will help to focus the resilience among the members of staff. This can be through maybe to keep on providing to provide ways or opportunities whereby they can have a meeting with the staff the staff can communicate back to them, so that the staff can feel they are supported in a way. They can also maybe, for example, through the use of supervision sessions. The supervision sessions, it fosters that support from not only the fellow colleagues, but also from the organization itself. We also have the social support networks. As I've said, they create a space for the staff to share, communicate, so as to lessen that burden of carrying the traumatic material home. And since it's an organization or an institution, most of the time it's not exactly always easy for the staff to just share. There has to at least be some established rapport. So maybe to facilitate this, they can have something like either retreats, or maybe they can have reception or something. Such opportunities whereby the staff will come in, not in their role as to work, but then to just come in and socialize freely with each other. They can also facilitate the training to sensitize vicarious trauma and on how the culture of compassion, optimism, and support will help to prevent it. It's with the knowledge, once you have the knowledge of what exactly vicarious trauma is, of what factors may contribute to vicarious trauma, of the resilience that actually to build what you may need to do to build that resilience, then you find that you may be able to prevent the secondary traumatic stress from coming in. Organization, as I said before, they could also invite the staff to share inspirationals or have client memorials and hold celebrations. For example, staff lunches that are organized around work anniversaries. This also helps. Once the healthcare worker or the service provider, once they are able to look back and they can see that the clients or patients, their growth, or hear the gratitude that comes from the clients, share such success stories, they will feel more motivated. It will help them feel more appreciated, and it will actually help in their support and building of their resilience. And that brings me to the end of my presentation. If you have any questions.
Thank you, Rebecca. Sorry about that. Yeah, so thank you for a very nice, well-presented presentation. It is timely, especially now that we are dealing with the pandemic, and we now invite questions. Huawei, while we have Yeah, whoever Y16, you had raised up your hand. You can unmute and ask your question. Vivian Amondi Country, you can raise, you can ask your question. You can as well post your question in the Q&A chat, and it will be responded to. Thank you again, Rebecca, for a well-presented facilitation today. You mentioned something on organizational way of arresting the vicarious trauma, and sometimes looking at, like, for example, Kenyatta National Hospital is a huge facility with several departments. I am curious how, as a small department, as a small sub department in a huge department, how can we ensure that we empower our staff with these skills such that they don't fall victims of secondary trauma?
Thank you so much for that question, Pauline. As I had said before, we can try to, in fact, within the departments, within those, just as the department, it will even make it much easier to organize for CMEs here and there regular training. It will also be good coming maybe from the department, for each and every department, to try and to make an effort to take into consideration the welfare of the staff. So you find that some departments, what they do, they budget, while budgeting the budget, the financial budget, some of them they budget for retreats, and these retreats actually they help the staff to unwind, which is something that also helps to release the burdens that they may be carrying during the interaction of their clients. Yeah, as well as now the facilitations of the CMEs that can be done through the department, and they can be taking the staff, creating a comfortable environment such that no staff will be embarrassed or feel judged if they come forward with an issue, or having or a state that they feel that they've been they are affected when interacting with their clients.
Wow, that's quite informative. Yeah, that's quite informative, and I like it because you're saying even as a small department, we can come up with a session by ourselves and facilitate it within ourselves and help us through. It reminded me when you mentioned about vicarious trauma and how it affects our social support system. It reminded me of a program we did sometimes back with the administration police in the headquarters after the Sinai fire tragedy. And I remember some of the officers, but this was senior officers, sharing how their worldview has been affected by the vicarious trauma. And one mentioned that since the Sinai tragedy, he's not able to eat nyama choma anymore because of the scenes and the smells that were coming from the fire tragedy. So it can really stream down to our families and our support system. And I like it because you brought it out very well, Rebecca. And so if you're there and you feel like you're struggling with vicarious trauma, it is high time that you seek therapy and see what you can do to cope with it. The other thing, Rebecca, that you mentioned is that sometimes vicarious trauma can change our cognitive distortions. Can you elaborate more on that?
Everyone has their own pattern of thoughts. You have your own philosophy, the self-philosophy of life. But then you find that often after being exposed to trauma, after being exposed to the vicarious trauma, like the example I was giving of a healthcare worker or a health professionals who most of the time they work with SGBV clients, you find that after having been exposed repeatedly, time and time again, to incidences, and most of the culprits, they're men, they tend to change maybe the earlier perception that they had, or the thought pattern too, and begin to view all men as people who are bad, people who are animals, and it tends to like stick, because all that day in, day out, all that they're dealing with are cases whereby the men are portrayed in such a way. So such alterations, they tend to come by. Yeah.
Well, thank you. Nicholas is asking that during the pandemic, we have seen an increase in domestic violence. How would this be explained from a psychological perspective? And what indicators can one look out for to mitigate against these situations?
Okay, most of the times, the domestic violence that have been increasing, most of the times you find that they may be as a way of projection. the pandemic itself, it has come with the, as I had said before, with the protocols that not many of us, actually, most of the population, they are not used to being restricted to movement, being restricted to in terms of the people they would like to relate with, the times that they have to go out, and even more, it has come to affect their jobs. Some have lost the job that they're holding to, what was actually their source of livelihood, and maybe even resorted to a lesser way of earning their income. So with all these resulting issues, it has now put a strain on the family system, because you find that now conflict begins to arise within the family. So that can be a factor. Another factor can also be that that extended period of time that they're now being forced to stay together, to stay within one house, and then there's the uncertainty of what will happen. There's also the frustration of where will we get your next source of income? What will you do as of now, and how will it impact? So that kind of further facilitates or kind of boils the conflict between them. And in my thinking, I find, and even with the most cases that I've handled surrounding domestic violence, you find that is those are one of the major factors that actually contribute to the violence.
Yeah, thank you. And maybe probably to add on what Rebecca has said, remember when she mentioned what we can do to mitigate, the interventions that we can do, under the individual aspect, there was the aspect of therapy. So it is important, if you are a health care provider, once in a while, like we mentioned last night, once in a while, just like we go to a doctor for a well-woman clinic, for a well-man clinic, once in a while, you can maybe probably make it once in a month if you are active in your service profession. Once in a while, visit a therapist and just have a moment of venting out. Remember, therapy is a very safe environment, an non-judgmental environment, and it is safe for you. So I like what Rebecca has put out, that we need to take actions to mitigate this so that we don't end up in domestic violence. And again, she mentioned briefly about the intrusive thoughts. You can imagine this person who has been working with, say, COVID-19 positive patients, and then the person gets home and the wife or the husband doesn't seem to understand where they're coming from. They might resort into domestic violence. So once in a while, let's visit a therapist, let's visit a psychologist, just to have that moment of working on ourselves. And this ends up in self-care, very, very important. Yeah, Evelyn is asking about the differences between moral injury and vicarious trauma.
Thank you so much for that question, Evelyn. For moral injury, I think it more or less focuses much more on the effects that that a trauma or any other factor may have on the philosophy of a person or on the morals and values that they had in life. Precarious trauma. I don't know whether you meant precarious trauma or vicarious trauma.
She's written precarious, but, yeah.
Yeah. So, because with vicarious trauma, what as we had just mentioned, it's more on that transformation, the process of the transformation, whereby you find that it's not only in terms of your view of the world, your personal philosophy being affected, but it also includes the behavioral, cognitive, as well as emotional self. So it encompasses basically all of the that's the whole the change of the whole process of the transformation that takes place in an individual who has been exposed to repeated exposure or extreme exposure to details of someone else's trauma. Yeah, so I think that's like the major difference between the two. On the one hand, one is specifically centered on the a person's philosophy of life, or the beliefs that they have, or the morals and values that they hold, while the other, it's now encompassing everything. Yeah.
Yeah, Ipin is saying she meant the difference between moral injury and burnout.
Oh, and burnout.
Yeah.
Oh, okay. Burnout, as I had mentioned, burnout it's more the state of exhaustion that one has, that comes with more after having dealing with the difficult clients, or maybe or the patients, or maybe when your role gets like too overwhelming. So after a certain period of time, you find that there's that extreme exhaustion that you face, and then the symptoms of each, they are quite different, because most of the times for moral injury, the symptoms will include negativity and cynicism. Those are one of the main symptoms of moral injury. But then with burnout, most of them will actually be centered on the ability of that individual to work. You find that they start coming late, they start reporting, they start ditching tasks, they start having high rates of absenteeism, and there's also irritability factor. They get angry, they tend to get angry quite quickly, and most of the times, more often than not, they're also the ones who they kind of start creating problems with even other, while relating to other staff members. Yeah, so I think that, from my point of view, is the major difference between the two.
And then on top of that, she's asking, as a health worker, how can does she mitigate this?
As a health worker,
yes.
With from self, or in wanting to help others. From self, as we had said, you have to take time to reflect about on yourself, you as an individual. Have that self-awareness. That's why we had mentioned the aspects of mindfulness and the reflection. Have that self-awareness. Know that yourself, this is my limits. I after getting there, you have to now like take a step back first before pushing yourself to provide any other services, because if you do that, you now be eroding yourself in your capacity to be providing that compassion. You find that it will now start leading to the empathic illusion. And another thing, if you are talking maybe in as a position whereby you'd like to help others, one of the main things you can do first for anything is to sensitize. The main thing is, once you have the knowledge, it will really help to mitigate the cases of vicarious trauma among the staff. And then another thing is to, as you are working with your fellow colleagues as a healthcare workers, you support each other. If maybe you are noting that a certain colleague is exhibiting such certain symptoms that to you really are manifesting as symptoms of vicarious trauma, either of compassion fatigue or burnout. Give them and assist them in a way that is not judgmental, but is genuinely being there for them. Yeah. So I hope I've answered the question.
Thank you. And maybe probably to add on what Rebecca has shared, it is advisable and it is very healthy to have 10 minutes of me time, 10 minutes of your time every evening, just to take a reflection and ask yourself, how was the day right for me? And what is that I'm taking back home? It is very, very important. Again, as a department, as a small group where you're working with, where you're working, you can come up as colleagues and have 5 minutes every morning just to check on each other and just to find out what is that we are struggling with. These are some of the things that we can do, very little things that we can do that will help us not to slip down into vicarious trauma. Zipporah is asking, what is the difference between vicarious trauma and secondary trauma?
Well, thank you so much for that, Zipporah. The vicarious trauma, it's more or less, as I had said, it focuses more on that the process of the transformation that occurs in an individual after having been exposed, in terms of their personal philosophy and also how they're affected psychologically and emotionally. So it focuses more on that, the process of transformation. Secondary trauma, on the other hand, is just basically the trauma that is incurred through exposure of the trauma that happening to someone else. And one of the main differences actually between the two is that vicarious trauma is most of the times associated with healthcare providers or those who are mainly working with traumatized individuals. But then for secondary trauma, you find that it's more associated now with civilians. For example, if maybe you get a call or you get to witness a loved one, or you are told that a loved one has gone through a certain traumatic event, or they have been through an accident or something, that will be secondary trauma. It will be a trauma that you have that you are experiencing, but that it has actually happened to someone else. It might even be a friend, or even be someone that you don't know, but then just hearing about what had happened to them, it affects you. Because remember, it's not only the healthcare workers who are exposed or who are in a position whereby they can be traumatized through a trauma that is happening to someone else. It all depends on one's past history, where they stand. If they are put in that situation, what is their level of resilience? So anyone can be affected. So that's why I'm saying the secondary trauma, it's more associated with now the civilians and the other group. The vicarious trauma is more or less for those who are specifically working day in, day out with the individuals who've been traumatized.
Thank you, Rebecca. And from your explanation and from what you've shared with us, I'm imagining we can cause our loved ones at home secondary trauma. Yeah. If you're working in a hospital setting and every time you go home, you're sharing with your husband, with your children, the experiences that you've had in the hospital, I think that would cause them secondary trauma, if I'm right. Yeah, and vicarious trauma is for you, who is the health professional working directly with clients. So that's why we encourage, instead of sharing with our loved ones at home, our experiences at work, we go and seek therapy, or we find our fellow colleagues just to debrief and talk about our issues. Otherwise, sharing with our loved ones at home might cause them secondary trauma. And this has happened. I've had babies come to me and ask me to tell their mummies to stop working where they are working, simply because mommy has been sharing of the experiences at her place of work, and the child feels mommy is not safe. So we may cause them secondary trauma. But again, Becky has put it very clearly. Thank you for that. Neon, I had seen your hand up. I don't know whether you're still with us. And there was also Pauline, whose hand was up. As they come and respond and ask their question, I think this is a very important topic, Rebecca, for all of us, such that we can have healthy lives at our places of work, healthy lives at our families, and if we take good care of ourselves, and most importantly, the self-care that you mentioned, I think we shall be able to mitigate this and help ourselves and even be able to give quality services to the people we are working with. It also reminded me of some work we did with the Kenya Defense Forces, the officers who came from Somalia some times back, and one family was sharing how they don't understand their loved one anymore because he had become so irritable. He had become he had started drinking, and this was as a result of the scenarios and the experiences they had back there in Somalia. So when we understand what our loved ones are going through, we shall be able to empathize with them and help them navigate what they are going through. Yeah, thank you. It is a very timely topic, Rebecca, and I like it. If you have any other question, you can post it in the chat even as we come to a close of our session this morning. We can hear you, Galaxy. Evelyn Anyango, you're saying you're in, but this time it's really challenging. I don't know whether you mean the time for the facilitation or what it is that you find challenging, but we hear you. We hear you, Galaxy J2. Nicholas is asking, can we say vicarious trauma is more likely primary trauma if such term exists?
Primary trauma, if there's the direct trauma that happens to that is now a person themselves, that they're being exposed to a traumatic event, and vicarious trauma on the other hand, it's more secondary, although it's a bit different from secondary trauma, as I had earlier explained, but vicarious trauma is more secondary in the aspect that it's not the traumatic event is not happening to you, but it's something it's a trauma, it's a traumatic experience of another person. And then having been exposed to that in one way or another leads you to now incurring the vicarious trauma.
Thank you. Evelyn Onyango is saying thank you. For her now, she understands the secondary trauma and its effects. Thank you, Evelyn, for your kind remarks. So if there are no more questions, I think we've come to the end of our presentation this morning. We trust that it has been helpful. Let's do what we can. This slide is short. Let's do what we can so that we are able to give quality services to those that seek our services. Thank you so much for joining. Thank you, Kenyatta National Hospital, University of Nairobi, for giving us an opportunity to give back to the community. God bless you and have a lovely day.